Hello, everybody. It's Jose Delgado with EPITalks. So today we've got Peter Beltran with Neuromed Inc. here again, and today we're going to be talking a little bit more about how his technology can still help your practice out, even with all of these new social distancing guidelines, how to adjust your revenue cycles, how to find some ancillary revenue in your practice, because I mean, it's getting harder to see patients out there, guys. I don't know if you've seen it, but going to a doctor's office, these waiting rooms are sparse right now, whether it's because of telemedicine or whether it's because of, just lack of patients being afraid to leave their house. So, Peter, how you doing today? Thanks for being
I'm doing
on.
great. Thank you. Doing great. Thank
Hey,
you
no
very much.
problem. No problem, no problem. So let's jump right into it because I like to keep these to nice and 20 minutes so that way we catch everybody on their commute. Especially with COVID, all these commutes got shorter. So how can Neuromed help my practice um, catch up with where my business plan fell in 2020?
Very good question. First of all, I'll basically let you know from the experience that we've had in the marketplace during these times and what doctors' concerns have been during them also. One of the things that we have noticed is, like you mentioned earlier, is that there has been a drop in patient visits to physicians, primarily because they were not really in place specific guidelines on what doctors needed to do in their facilities, the social distancing, how to really get things in order to be able to open up back into their facilities. So telemedicine really took off, tremendously. With that said, one of the things that we were finding where doctors were concerned about was a lot of these patients who had a pain condition, let's say like a low back, got to the point where they were actually going to the emergency room. So the emergency departments and the hospitals just came back and said, we can't be seeing these type of patients in our facilities. So it threw it back into the doctor's practices. So
Okay.
because of that, we've seen an increase in these physicians really looking at ways of treating these pain patients in their own office. Of course, still containing with the social distancing and, monitoring the patients as before they come in, cleaning the area that in which the treatments are being performed on, and it's been very, very successful for a lot of these doctors because like we mentioned earlier, is that it is reimbursable. The insurance companies are covering this technology and have been for over 30 years.
Interesting. Interesting. So, I mean, I do have some experience with your machine and your technology, and I've been able to see what it does for patients, and it's definitely something for me. Where what is the difference between what offices and facilities were doing before versus what they should be doing now? Because you even have protocols in place for how to clean the machine and clean the things that are making patient contact in between, and I don't think that there would be much of a change really in the logistics of me grabbing a patient, bringing them back, setting them up, and then pushing a button. Am I wrong here, or is it kind of the same for you for the day
Right,
to day use of the machine?
right. Well, yeah, the day-to-day on our technology, because it is an unattended type of treatment on a patient, it's really just setting up a patient and basically, entering specific programs on the system itself, and being able to monitor every so often, what's going on the unit itself. So nothing has really changed on our part. It's just more now that the doctors feel more comfortable knowing that they can bring those patients into their facilities who are having, pain or circulatory disorders, bring them in, and who have been concerned about overprescribing of the opiates for their patients. And the main thing that we've seen is really a lot of these general practitioners, family practice guys, not having to refer these patients over to a pain management guy or personnel. So now they're actually keeping those patients in-house and basically practicing pain management.
Gotcha. Okay. So you said a magical word that kind of that that I can already tell legal is going to be calling me later. Because as soon as the doctor starts practicing pain management, depending on their jurisdiction and the insurance they're talking to, it it can get very um, chaotic. Let's use that word. So, would this be considered pain management? Would this be considered PT? Would this, so if I'm a
Yeah.
doctor coming to you saying, "Hey, I want to put some I want to take advantage of the fact that I have so many patients that are on opiates or I'm prescribing opiates because of pain," you know, how would we get around that pain management terminology?
Right. Well, the terminology itself, when we refer to as pain management, as a medical practitioner, they really can do a lot of things under their license. So they're not basically strict only to one condition. Now, when it comes to their education, that is a big factor also. So we encourage these physicians. So if they are a family practice doctor, as an example, and they want to get into utilizing our technology, and it is physical medicine treatment. That's what this device is all about. It's under physical medicine, and that's what the coding is like, even for the insurance companies to reimburse, for example, like Medicare and Medicaid. But what we're finding is that we encourage for these doctors to actually start taking pain management classes. Some doctors will actually get themselves board certified in pain management as a PM&R, as an example. So it's not something that they're told they can't do. It's just something that we say, if your profile with the insurance company is family practice and you start doing something different with billing, yeah, they're going to have questions because they've never seen you do these type of billing codes. But if you let them know in advance that this is what we're doing, this is how it's going to work, and send them a letter that you are going to be taking it, there is no issues with a lot of these physicians. So like I said, we've been years, and doctors have had really good concept, been audited by the insurance companies, including Medicare, and really have had no issues.
Okay, so you would say if you're looking to implement something like this, which actually that's not a bad tip in general, that if you're going to be implementing a new program, make sure you at least have a conversation with your carriers to make sure that one, they'll pay out, and two, if there's anything that needs to be modified in their profiles. That's actually a great tip. I'm gonna have to remember that one for all the different clients and different programs that people come up with, because that can save a lot of time on headaches. A
Oh,
lot
yeah.
of time headaches.
Yeah, be proactive when it comes to your practice.
Absolutely, absolutely. So when it comes to what kind of options there are to acquiring this ancillary revenue generation, what are the kind of things that a practice would need to be looking at to implement something like what Neuromed offers?
Yeah, in the sense of basically being able to provide physicians options to, one, the opiates, heavy narcotics, and especially the concern that we see a lot of physicians who basically have lost not only because of a COVID, but also because of, what's happening in the DEA, cracking down on doctors prescribing medication, heavy medications for their pain patients. So you're seeing a lot of doctors just saying, I don't see pain patients any longer. I'm referring all that out. So what we're telling these physicians is you can keep those patients in-house, by treating them with our technology, number one. It is reimbursable, which is kind of nice. The average reimbursement from Medicare and Medicaid, as an example, and I use Medicare as a guideline, it's anywhere between $45 to $75 per visit for the physician. And they're allowed between 15 to 20 visits per diagnosis.
Got it. Got it. Okay. So you can really build a nice treatment plan over the course of 3 to 6 weeks, depending on how the frequency. Hell, almost 3 to 8 weeks, depending on the frequency.
That's correct. And typically what the scenario that we basically give a lot of the physicians is, every 5 visits, reevaluate the patients, see how the patients are responding. Because, if you don't see several factors, if you don't see increase of range of motion, if you don't see long-lasting pain relief, in other words, the first visit, they should see about 2 to 4 hours of pain relief. The second visit, 4 to 8. So it starts lasting longer and longer and longer. So after about 5 visits, if they don't start seeing those type of changes, they need to start changing their treatment plan, their protocol on the device, as an example. But if they see these changes occurring, continue with the sessions that they've actually been providing these patients.
Interesting. Interesting. So, what kind of personnel can use this kind of a machine? Because, I mean, um, I imagine that since they're not constantly monitoring it, it's not someone that has to physically be on that machine, and their whole life is soaked around the machine, kind of like an ultrasound an OBGYN, where it all they do is that one ultrasound machine and just click 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 click, take pictures all day, all that fun stuff. So what kind of investment is a practice looking at?
Yeah, time-wise, for example, in a lot of cases, a lot of these physicians, they actually have their existing staff actually get trained and certified on the technology, as example. But when the patient actually is on the premises, there has to be either a physician on staff or even a nurse practitioner has to be on staff. Or on the premises, for lack of words. So as long as they're on the premises, the staff is actually working underneath that practitioners' supervision and also license, as example. So there are times also that the doctor or the primary care practitioner would kind of just really quickly just check in on the patient. How are you doing? What's your pain level? Just a very brief one-on-one contact with that provider and the patient.
So then, in this age of telemedicine, a provider would have to be on site. So if I'm a smaller office and my provider is working from home, the MA or RN or whoever wouldn't necessarily be able to do it then, would they?
It depends on the states and the locations, but my typical understanding and how I always tell a lot of the physicians is check your local providers. But I know that basically on a national level, we've seen that the doctors feel more comfortable being on the premises or their nurse practitioner being on the premises. Some of the doctors actually will hire a physical therapist or a chiropractic doctor to actually be on the premises, because that all works under their umbrella and their scope of practice also.
Okay. Okay. So then this would be something that you would say, if I wanted to incorporate an entire kind of physical medicine aspect, this would just be one piece of it, not even just treating soft tissue pain.
That's correct. So they are basically looking all different types of pain conditions, from, knees, shoulders, backs, hips, sciatic pain. I mean, we've seen so many protocols in place that physicians are utilizing the technology with, and very successfully. I've got some doctors that basically see patients that basically looks like they might be scheduled for surgery, and just try it out to see if they can avoid that. And a lot of cases that has happened, where basically patient didn't need the knee surgery or the carpal tunnel surgery, as example. Only because you've got that information down, you've got the results you're looking for, and then after that, just really proper exercises that physical therapy can actually teach patients to actually do at home.
Okay. Okay. So then, um, you're looking. So right now, I'm seeing that commercial space is cheap. So just because of how many people are realizing they can do the same job or 90% of the same job from home. So if I was a doctor, is this something that what kind of space would I need in order to look at doing something like this?
Yeah, I would probably say it's something very small. I mean, even the existing treatment rooms that doctors have right now that they see and evaluate the patients, it's really fits in those type of rooms. So it's nothing really large, and it's mobile. So that way the doctors can actually move it from room to room, or the staff can move it from room to room to treat different type of patients also. So it's
Okay.
not really that large of a medical device.
Has it gotten smaller? Because if it's about the size of an all-in-one printer, all-in-one office printer.
Yeah, that's exactly it. That's a very good analogy behind it. I've always said if people are my age, they probably remember the old record players. It's about the size of that too.
Record player? What is this record player you speak of?
I know.
No, that's nice. That's nice. Okay, cool. And then do you foresee any, because there's going to be some coding changes. When I sat down with Tessie, Diegues, and Trinae from Stat Billing a little bit ago, they mentioned that there was going to be some changes in some of the coding aspects for office visits. Do you know if there's going to be any changes with the kinds of codes used for the machine and these treatments?
No, we really haven't seen any changes at all on it in the past 30 some odd years. Even looking forward, uh, as example, there has been no change in regards to the coding themselves either. So it's all diagnosis driven. That's the unique thing about our technology. So as long as the doctor has the proper diagnosis, there are specific billing codes that would be applicable
Nice,
for them.
nice. So then, what kind of settings would be most beneficial in bringing someone like you in and something like this in? I know that we mentioned chiropractic, physiatrist. I imagine because of those two mentions alone, PT and ortho would also be pretty good. Family medicine you mentioned would you see something like peds just
Yeah,
because
I
of the
would probably
sports
say
injuries?
yeah, for sports injuries, we're very heavily in that market. Of course, these athletes, multi-million-dollar athletes, they're paid to be on that field, and that's the worst thing that can happen is when they get injured. Of course, they're going to be on the sideline. One, somebody can take over their job, but number two is they don't make as much money as they would if they were actually on the field playing. So, having said that, that's one aspect. Is sports teams or sports injury physicians who want to definitely focus on that. The other type of practitioners that we have focused on all these years, of course, have been your pain management doctors, anesthesiologists, the neurologists. But in the last probably 15 years, we really branched out because of the demand by the general practitioner, the internal medicine. We've got rheumatologists involved with our technology. So
Interesting.
that's really been the big market that we have focused on because it is a medical technology that doctors are utilizing and very, very high specific parameters behind it also.
Okay. Wow. All right. So there's it's pretty much who can't use it more than a who can for you. It seems like almost what half the medical field could be able to use something like this in their office. That's very interesting. Very interesting.
Yeah, we would probably add on to that basically that as long as it's a licensed provider, as example, they really do have the capability of implementing this into their facility. Now, it depends now on the insurance provider on if they reimburse it to that practitioner or not. But in a general setting, when it comes to the medical practitioners, MDs, DOs, as example, nurse practitioners, as example, they all get reimbursed by all the providers.
Wow. Wow. Okay. All right. Nice. So then, if I wanted to learn more, is there a certain salesperson that you have for certain areas? Do they contact you directly through neuromedinc.com? How would they reach out to you, Peter?
Yeah, the scenario basically is if the doctors really want more data, more information on it, they can go to our website, request information, and we'll be more than happy to send them information about it. But also, we have patient testimonials, we have physician testimonials on our website, so that way they can get an idea of what this is. We actually have peer-reviewed studies that have been published in the past on this type of technology. So it's not new. Like I said, we've been around for over 30 some odd years in the market and been reimbursed by all insurance providers. But at the Cleveland Clinic is where the technology is located at. Up in Ohio, Columbia University, Loma Linda, Bethesda Naval Hospital, over 3,500 practitioners nationwide. This is what they're implementing in their practice and been very
Interesting.
successful at it.
Interesting. Well, I mean, you've been at it for 30 years. I mean, you don't follow good money after bad, especially for that long. So you definitely got to be doing something right. So then, no, I mean that's that. I'm looking forward to seeing you again in April at the Portofino Bay Hotel when we have our EPI conferences. Hoping that COVID won't shut us down for a second year in a row, and so we can have some fun there. And I do believe that Peter, we are going to be having a CME course with your machine at the conference. I know that we're working on that as well. So that is going to be something that that everybody's going to be able to apply for at the EPIConferences.com website as well. So if you've got any questions, or if you're interested in getting some of your staff certified, or you need some CE credits in the beautiful city of Orlando, uh, keep us in mind for the beginning of April next year. I believe it's the 9th through the 11th. My secretary always gets mad at me because I get those days mixed up. But it'll be a Friday, Saturday, Sunday. So this coming year to be a little bit different, Peter. So you have to take that Monday off so you can hit the parks. But
No
yeah,
problem. Yeah, actually, we're actually working right now with one of an anesthesiologist that has basically offered to lecture at your facility upcoming
nice.
event. And this is an anesthesiologist from the state of Ohio who's used this technology. And you know, these anesthesiologists, it's all epidurals. And
Yep.
he basically has a different take on what and the reason why he utilizes our technology, especially on some of these patients that really you can't give an epidural block on them because of, you know, they're older, they're on blood thinning medication. That's where this technology really falls in hands. So he wants to talk about that.
Okay. Well, I look forward to actually sitting down. A lot of that's probably going to go over my head clinically, but I'm here to help everybody out and make sure everything runs smoothly. So, Peter, I want to thank you again, guys. You stay happy, you stay healthy. Keep on working. Make sure to check us out at EPIConferences.com and Peter at neromedinc.com, and we'll be looking forward to seeing your pretty faces in April. All right, guys. Have a good one.
Look forward. Bye-bye.